for you to understand the functioning of a prosthesis, of a V-disc prosthesis. You see, this is the ring of the prosthesis, and here are the two hemidiscs that are closing in an horizontal position, and then they become perpendicular to the plane of the ring in the open position. And three orifices are generated, two lateral orifices, which are larger, and a narrow orifice in the center of the prosthesis. Apart from echo, as I told you, cinefluoroscopy may help us to evaluate the functionality of a prosthesis, and then cardiac CT may be used for a better visualization of calcification and degenerative changes of biological prosthesis. Please remember that in patients with biological prosthesis, the changes, the calcifications and the changes on a biological prosthesis are very similar to those happening on a native valve. The tissue is very similar, so it happens, all that it happens on a biological prosthesis resembles the changes on a native prosthesis. The use of cardiac magnetic resonance is not a routine, is rare. Another thing about the cardiac CT that you should remember is that it will help us to make the difference between a thrombus on a prosthesis and the pannus formation. Pannus formation, as I told you, means that is a lot of fibrosis that forms on the ring of the prosthesis in time. It's an autoimmune reaction to the prosthesis. What about the treatment of these patients? Well, in patients with mechanical prosthesis, anticoagulation is mandatory, and the only anticoagulants, oral anticoagulants that we may use are the anti-vitamin K anticoagulants, lifelong for all patients with mechanical prosthesis. Okay, apart from if we are in a situation when intravenous anticoagulation is necessary, we can use heparin. But if we need to anticoagulate the patient on long term, we should use oral anticoagulants, and only the anti-vitamin K anticoagulants are recommended. You will hear about new anticoagulants. They are not currently recommended in these patients. On the other hand, in patients with biological prosthesis, anticoagulation is recommended for the first 3 months after surgical implantation of a mitral or a tricuspid bioprosthesis, or for an aortic bioprosthesis sometimes. But after the first 3 months, anticoagulation is no longer necessary in patients with biological prosthesis. However, if atrial fibrillation is present, if there is a patient with a history of venous thromboembolism or with a hypercoagulable state, or if there is a severe LV dysfunction with an ejection fraction below 30, then anticoagulation should be considered even after this short-term period, but for other indications. Otherwise, the anticoagulant treatment can be stopped after 3 months from surgery in these patients. What about the target INR in these patients? Do you know, in a patient with atrial fibrillation, do you have any idea about the target INR? So we are using, so tell me.
2 to 3, maybe?
Yes, yes, perfect. Between 2 and 3. Well, in patients with prosthesis, the INR in some of these patients should be higher. Today, because the prosthetic valves are better than in many years ago, in patients with aortic prosthesis, B-disc aortic prosthesis, the INR should be maybe between 2.5 and 3. Because the prostheses in aortic position are less predisposed to thrombogenic, are less thrombogenic. And why is this? Because the velocity of the flow through the prosthesis in the aortic position is higher than the velocity of the flow through the mitral prosthesis. The pressure gradient between the left ventricle and the ascending aorta is higher than the pressure gradient between the left atrium and the left ventricle in diastole through a mitral prosthesis. This is why for patients with aortic prosthesis, we can keep an INR between 2.5 and 3, whereas in patients with mitral prosthesis, the INR should be higher, between 3 and 3.5. And in older types of prosthesis, the INR was even, the recommended INR was even higher than that. This is an important slide. Please, this is something that you have to keep in mind also for your exam. This might be a question. The complications of prosthetic heart valves, okay? And you should know that the first complications that we fear in a patient with a prosthesis, particularly in a patient with a metallic heart valve prosthesis, is thrombosis. This is a feared complication because it may have dramatic consequences. Related to that, but not only to thrombosis, the patient may present with embolic events. These embolic events may be due to thrombosis or maybe due to another complication, which is infective endocarditis. Infective endocarditis means the infection of a prosthetic heart valve. It is associated with vegetation that will form on the prosthesis, and parts of these vegetations, or if it's a thrombus formed on the prosthesis, parts of this thrombus may be released in circulation and may lead to embolic events, which may be cerebral or will lead to limb ischemia or in other territories. So these are three important complications: thrombosis, infective endocarditis, and embolic events. Another complication is pannus formation. Related to infective endocarditis, the prosthesis may detach from the native ring and dehiscence will occur. Another complication, which is not rare and not less severe sometimes, is hemolysis, and we will talk a bit later. Structural deterioration is usually associated with biological prosthesis and not so much with mechanical prosthesis. It's quite rare, the structural deterioration of a mechanical prosthesis, although it's not impossible because sometimes the prosthesis may have a defect from fabrication, or it may happen, but it's very rare. However, biological prosthesis may deteriorate in time. Here are associated complications, are complications that are rather associated to this main complication on the first column. So, of course, these embolic events may lead to myocardial infarction. So, if you will have this subject on your exam, please remember that the first column are the main complications of a prosthetic heart valve. And if you have time and if you want to be more complex in your answer, you can add that associated complications of these main complications may be myocardial infarction due to an embolic event. For instance, if the patient presents with a thrombosis or endocarditis on the aortic prosthesis, parts of this material, thrombotic or infectious, may go into the circulation and may lead to myocardial infarction, for instance, or to other ischemic events. On the other hand, if there is a thrombus on the prosthesis, which leads to the occlusion of the prosthesis, it will lead to heart failure, to rhythm disorders, or if there is, let's say, an infection associated on an aortic prosthesis, this infection may spread around the prosthesis and may affect the conduction system and lead to conduction abnormalities. In fact, when we see conduction abnormalities in a patient with an aortic valve prosthesis, we are thinking on infective endocarditis. What about prosthetic valve thrombosis? It is a complication mainly associated with mechanical prosthesis. However, cases of thrombosis on bioprosthesis have also been reported after surgery or transcatheter valve implantation. So it is mainly associated with mechanical prosthesis, but thrombosis may occur also on bioprosthesis. The reason why we don't know so much about the thrombosis on bioprosthesis is that thrombus on a bioprosthesis may be seen only with cardiac CT, may be suspected with echocardiography, but may be confirmed with cardiac CT. And the availability of the cardiac CT is higher now than it was in previous years. So lately, during the last 1 or 2 or 3 years, thrombosis on bioprosthesis have become obvious. We can suspect this kind of the thrombosis on a bioprosthesis also with echo, because there is an increase in transprothetic gradient. However, this is only a suspicion and should be confirmed by cardiac CT. What should we do with a patient with a prosthetic valve thrombosis? Anticoagulation is the first line treatment. And the thrombotic risk, remember, that is higher with tricuspid prosthesis, a bit lower with mitral, and is minor with aortic valve prosthesis. Clinical presentation in a patient with a prosthetic valve thrombosis may be acute when the thrombus is interfering with the opening or with the valve. So the valve will have a very high gradient in echo, and the patient will experience hypotension, dyspnea, acute heart failure, or embolic events. In very rare occasion, it can be only an echocardiographic finding, but that means that there is no much interference between the position of the thrombus and the function of the prosthesis. On auscultation, we will find a new murmur. If there is an aortic prosthesis, for instance, or a mitral, rather a mitral, because usually the thrombus will form on a mitral prosthesis. And if the thrombus interfere with the opening of the valve or with the closure of the valve, we will hear an aortic regurgitation murmur or a murmur of mitral stenosis. But we should suspect promptly a thrombosis of a prosthetic valve in any patient with any type of prosthetic valve who presents with recent dyspnea or with an embolic event. Then the diagnosis should be confirmed by transthoracic or transesophageal echocardiography, cinefluoroscopy, or CT scan if promptly available. And here we have an example of a mitral prosthesis with a thrombus interfering with the opening of the valve. Here is the transthoracic echocardiographic image. It's an apical 4-chamber view. Is there something, in this case, do you see here that, can you see that there is a mitral prosthesis? Is it clear?
Yes.
What which are the elements indicating that the presence of a prosthesis? What do you see?
The hyperechoic structure.
Yes, and we can see the 2 discs. It's a bidisc prosthesis. You see, here it's 1 disc which is immobile. You see, it's a fixed structure. And here we have a mobile structure moving up and down, which is one of the other disc. This is one of the discs and this is the other. However, I agree that it is not very clear what is happening on this prosthesis on transthoracic echo. So we should go to transesophageal echocardiography. And what do we see here? Look, here is one of the discs which is fixed within this thrombus and it's not moving. And here is the other disc moving up and down. And the patient, in this patient, the flow in diastole will go from the left atrium into the left ventricle through this narrow orifice that remained due to this disc which is still moving. If this patient would wait a bit more, then a massive obstruction of the prosthesis with thrombus may occur, and the patient may die before reaching clinical help. So, but anyway, in this stage, the patient is very probably symptomatic by dyspnea mainly. So, yes, he presented to the emergency room, and we have seen this mass interfering with the opening of one of the discs of this prosthesis. And here what you see is more thrombus into the atrium. And you see, this is a spontaneous contrast within the atrium, this swirling cigarette smoke appearance. You see, that means that in this patient, the anticoagulation is not good. It's a very bad level of anticoagulation. Maybe the patient forgets to take his pills, or maybe the patient did not check his INR monthly as recommended. What can we see in this image? A turbulence across the prosthetic valve. A turbulence, and this aspect of sunrise, you see, this hemi disc, which indicates that the flow is going through a narrow orifice, and distally from the orifice, the turbulence of the flow. As I told you, when the flow goes through a narrow orifice, it will be accelerated with high velocity and the appearance will be turbulent. And in this image, we have the Doppler envelope through the mitral valve. In this case, the transducer is always here, as I told you. The flow is going from the left atrium to the left ventricle in diastole. This is the mitral valve, and during the systole, the mitral valve is closed, and there is a mild mitral regurgitation. It's this small red flow going back into the left atrium. It's a mild mitral regurgitation. This is mainly a turbulent diastolic flow. So we will get a negative envelope because this is the flow going away from the transducer. And by tracing this envelope, the echo machine will give us the maximum and the mean gradient across the valve. And the mean gradient, I can't see here very well, but I think it's 14, it's above 10 anyway, which means that it is a severe obstruction of the mitral prosthesis. And there is another nice aspect that you can see here. On two different cardiac cycles, as you can see, there is one envelope is more intense and one envelope is less intense, which means that the obstruction is not the same with every cardiac cycle. It's more important with one cardiac cycle, and so the valve sometimes moves better than other times. It depends on the position of the thrombus. So this is why this envelope is not so intense as this one. This is why when assessing a prosthesis, you should wait for several cardiac cycles. Sometimes there is an intermittent obstruction of the valve. So you should wait and see if everything is normally working with the prosthesis. In this case, In this particular case, as that I told you, heparin should be immediately injected to the patient, and emergency valve replacement is recommended if the patient is critically ill. If the patient is tolerating this situation, the valve replacement will not an emergency, but it will be urgently performed. Of course, surgery should be considered also if there is a very large thrombus, even if it's non-obstructive, because it will not go away. It will remain there despite our treatment with heparin. And in this case, surgery should anyway be performed. And fibrinolysis may be considered. So it's the last option if surgery is considered to be at high risk. However, there is with fibrinolysis, there is always a risk of bleeding, of hemorrhagic complication, and of thromboembolism, because with fibrinolysis, the thrombus will be ruptured, let's say, in small parts, and those small parts may lead to ischemic complication. So this is not our first option. It might be an option in patients with obstructive prosthetic valve thrombosis that are not candidates for emergent surgery. In this case, we may try with fibrinolysis, but it is a risky choice. Embolic events, I will not insist so much on embolic events. I told you that mitral prosthesis portend the highest risk of embolic events. What about the pannus? The pannus represents the deposition of a material on the periannular tissue, so along the ring of the prosthesis and not so much on the discs of the prosthesis. This is one argument to make a differential diagnosis between thrombus and pannus. Pannus is usually originates in the neointima of the periannular tissue and is formed of collagen and elastic fibrous tissue and endothelial cells, chronic inflammatory cell infiltration, and myofibroblasts. It's a bioreaction to a prosthetic heart valves. So all these cells will migrate from the exterior tissue and will make deposits on the ring of the prosthesis. However, sometimes the pannus can be, the pannus mass can be large, and then it will interfere with opening and closing of the discs. The risk of pannus formation is 3 times higher in the mitral position. It may be formed both on biological and mechanical prosthesis. On echo, it has a bright echo density and is attached to the valve housing, which means it is attached to the ring of the prosthesis and not so much on the valve. This is a case of another thing that you should remember is that pannus needs a long time for formation. So usually we will find pannus on prostheses that were implanted more than, let's say, 7 years ago. It's not a rule. Nothing in medicine is a rule. It may happen in some patients earlier, but usually you will expect to find pannus on a prosthesis older than 7, 8, 10 years and even more. A biological prosthesis has an expected lifetime of at least 5 years, where some mechanical prosthesis may be normally functioning for 20 years, even 30 years. However, pannus is more frequently found on mechanical prosthesis due to this fact that mechanical prosthesis have a longer lifetime. The consequence of pannus formation in this case, there is a mitral prosthesis, will be a mitral stenosis of the mitral prosthesis, or sometimes a regurgitant jet. I will not insist on prosthetic valve endocarditis because it is very similar with what you already know from endocarditis on native heart valves. Staphylococcus aureus is the most common etiology of prosthetic valve endocarditis in the early period, below 60 days after implantation. What about late prosthetic valve endocarditis? It may occur after 60 days after prosthetic implantation, and although Staphylococcus aureus remain an important cause for prosthetic valve endocarditis in this time frame, primarily due to the frequent exposure of the healthcare system in this patient, the microbiology of this late onset infection resembles more closely to that of native valve endocarditis. For the diagnosis, echocardiography, transthoracic, and the most important transesophageal is very important. These are first-line imaging tools, and we should look for vegetations, abscesses, or fistula. Treatment often involves a combination of medical and surgical approach. We usually start with medical therapy, and then surgery will follow if there is a dysfunction of the prosthetic heart valve. Surgery will be urgent if there are acute heart failure symptoms in the patient with prosthetic valve endocarditis. Don't forget about the antibiotic prophylaxis in patients with prosthetic heart valves that are going to dental therapies, for instance. It is very important to give them antibiotics, because otherwise the risk of prosthetic infection is very high, and is not only about dental therapies. In any invasive medical approach, in a patient with prosthetic heart valves, antibiotic prophylaxis should be considered, should be given. Here is the image that you have already seen. In a patient with infective endocarditis, there is a dehiscence of the prosthesis from the native valvular orifice. With a rocking motion of the prosthesis, it is an exaggerated motion of the prosthesis. In this case, the surgery should be urgent. Structural valve deterioration usually occur on biological valves, like calcifications, leaflet tear, and are more rarely found on mechanical valves. Surgery will be performed in symptomatic patients with significant prosthetic dysfunction. And now, just a bit, if you can pay attention, on hemolysis. Hemolysis can be valve related, and it usually occurs on mechanical heart valves, but they may be found also on biological prosthesis when there is dehiscence of the prosthesis from the native periannular tissue. Why does it happen? The red blood cells are passing through a mechanical valve, and this may lead to the rupture of the red blood cells, or if they are passing through a small orifice near the prosthetic ring, if there is a small dehiscence of the prosthesis, they suffer the same phenomenon of rupture when passing through a small orifice in patients with paraprosthetic leaks. In this case, anemia may be significant. It's not necessarily a mild anemia, and in some patients, a severe anemia due to hemolysis on prosthesis may be an indication for surgery. In some patients, it is not possible to solve the problem in any other way. Nowadays, a possible, of course, that redo surgery in a patient with a prosthetic heart valve is not something very easy to be done, because the risk in a second operation is higher than the risk in a first operation. And today we have some other options, and one of these options is to put an umbrella, a device like an umbrella, which is introduced percutaneously, and to close the small orifice near the prosthesis by putting in this orifice a device, a rounded device like an umbrella, which cover the orifice, and in this way the process of the main cause of this hemolysis is alleviated. Okay, so these are the main things that I wanted to tell you today. If you have questions. I will send you the PDF of this course too, and please read again. It was a lot of information. Not everything will be a question in your exam, and if I will suggest you to read the main, just to study a bit the main complications, to know the difference between the two types of prosthesis, biological and mechanical, the main differences between them. So the differences and the main complication, and to know how to select a prosthesis for a certain patient, considering some of the factors that I presented to you. This might be questions per se, or you may find these questions as clinical cases. Okay, so anyway, after this course, if you have questions, please ask my colleagues or myself, and please clarify these issues before your exam. If you don't have any other questions now, I wish you all the best, and we will see after the Christmas. Okay?
Thank you.
Thank you.
Thank you. Crăciun fericit.
Thank you very much.
Fericit și vouă. La revedere!